Maybe I could start by just asking you a little bit about your background and your early education.
Yes, no, I grew up in a small town in the south of Sweden, and then we moved to the countryside where my father was a clergyman in the Swedish church, and actually I lived very close to a church from the 12th century. I went to school. I was interested in not in biology. I was interested in mathematics and literature, and first I tried to find a way of combining these, and I was first interested in becoming a civil engineer, but then I decided to test medicine, and I was not very happy in the beginning, but then we have lectures in anatomy of the nervous system.
This was in Lund?
That was in Lund, at the Lund University,
yeah.
where I started to study medicine in 1967. And with these lectures, I found my niche. I found that this was something I would like to work with and do research on. So I immediately after the course in anatomy had finished, I started to work in parallel to my medical studies, to work in anatomy, and started a project which didn't go very well at all, but I learned a lot about how to do animal surgery, how to plan experiments, but of course it didn't end up in any PhD thesis because I had no supervision. So therefore I decided to move to histology, where there was a fascinating environment which had been built up around, initially around Nils-Åke Hillarp, Bengt Falk, Arvid Carlsson in the early 1960s. And when I entered the room of Bengt Falk I know exactly, it was on the November 30, 1969. It was because I knew that this would be fascinating. If they could accept me as a PhD student there, I could have there were a lot of things to do. It was extremely dynamic environment. And Bengt said that I could start there, and then I worked there, did my PhD thesis in 1974.
Was that after you had finished your medical studies?
Yeah, my medical studies in Sweden at that time, it was not uncommon that in the middle of your medical studies that you actually took a break, and then you did a PhD in more basic research. And I studied medicine for 4.5 years, so I did surgery and medicine and some clinical courses, and then I did my PhD, which was about developing a new method for demonstrating with high sensitivity the anatomy, the distribution of the dopaminergic neurons in the brain. So this is the link to Parkinson's disease, of course, but so that was the methodology. I did a lot of anatomical studies in the 1970s, but then in 1975, I decided that even if I was offered to continue in basic research, I wanted to see patients. I wanted to work with people also, and I felt that if I could combine having a basic science group with doing clinical work, I could do something which was not so common at that time, and that is actually what was my aim. But when I came to the clinic in 1976 in neurology as a young physician, I experienced the clinic as a completely different world. That basic science was one thing, clinics and clinical research was something completely different. And I had a lot of, let's say, I didn't feel that the type of research I was doing had anything to do with the clinic. And my boss in the clinic, who was really a fantastic clinician and teacher, he really didn't understand at all why I was interested in repairing the brain and the plasticity of this system, which there had just been some new data coming up, so that it was a quite difficult time in the beginning.
And I mean, just to go back a little bit, were you the first person in your family to go into medicine?
Yes, I was.
There's no dynasty of medical doctors in your family?
Not at all. On my mother's side, my grandfather, he was a quite famous musician actually, and my father came from very, very poor conditions, and there were no academic education at all in his family, and he was the first one who went to university, right. Became a clergyman. I think he was a very good clergyman, but also because that was the only possibility he had to get funding for his studies at the university.
And did you actually start to do engineering, or did you were interested in civil engineering, but did you actually start the course before you changed to medicine?
No, I changed just a couple of months before I was going to university. Right. So I actually worked for half a year. In psychiatry, not of course as a physician, but I worked for half a year, and then I started medicine.
So you kind of got involved in histology and anatomy, and then decided to go back to do clinical medicine for a while. And then what happened next?
Yeah, what I did, of course, was that I then became a specialist in neurology. I worked very hard in the clinic during daytime. Then in the evenings, I was working in the lab. On the weekends, I was working in the lab, and I tried to combine these two, and which was very, very tough, actually. And I think that it was before I started a family, because I was really working all the time. What was really triggered my interest in combining these two were the new findings in the late 70s, that there was a plasticity in the nervous system, that maybe you could even transplant cells to the nervous system and then get them to survive. That was in rodents, and I think that triggered a lot of interest for me to try to see, can we do that? Can you repair the human brain? And which none of my colleagues believed would be true, but actually that was very much a starting point for me.
And of course, members of the Movement Disorder Society will know you best for your pioneering work in fetal implantation. Can you tell us a little bit about the story? I mean, this was a very courageous step to start to implant fetal tissue into brains of even animals, never mind humans. So just tell us a little bit about the story, how it began.
For me, it actually, in 1979, there were 2 articles published. One from a group at Karolinska together with collaborators in the United States, Lars Olsson, Åke Seger from Sweden, and Mark Perlow and some others from the United States, and then by Anders Björklund and Ulf Steneve from Lund. And what they had shown was that you could take fetal tissue from rodents, from rats, and put them into the brain of rats with an experimental Parkinsonism. And you could see some functional recovery in those animals. And when I heard about these studies, I immediately realized, and it raised the possibility that you can actually take this perhaps to the clinic. But this was fetal tissue, and I think that there were 2 problems with this. One was that the practical thing, that because you would need to use human fetal tissue, could you really take this from human fetuses, from aborted human fetuses, identify where you have the dopaminergic neurons, and put that into a patient's brain without adverse effects? But I think mostly the ethical question, the ethical problem, is it ethically and morally justified to do this? And that was something where I think my background and in a religious home, and my father, who was then still active as a clergyman, I had a lot of discussion with him, because this is not just a matter of getting approval by the ethical committee. It's very much a personal standpoint, and it's something which took time from me, and but after very careful consideration, I came to the conclusion, which I defended since then, that it is ethically and morally justified to use tissue from fetuses, and also tissue from human embryonic stem cells for this purpose in severely disabled patients. And I think that's something which is, of course, it's not an easy question, but that is my personal standpoint.
So what happened next?
What happened next was actually not that we started with human fetal tissue. Actually, the next thing that happened was that I met with Lars Olsson on a meeting in 1983, and they had actually put adrenal medulla tissue into 2 patients with Parkinson's disease. It had not been published yet, but that had been, they had done it, and we started to talk, and it turned out that there were very little of neurological assessment in the study, so they hadn't done very much of work to demonstrate any benefit. And the other thing was that they had put the grafts in the caudate nucleus. So we decided to collaborate, and we decided then that we should operate 2 patients in the putamen with more careful neurological assessment. So I did that together with the Stockholm group in 1985 in 2 patients. That was, it went well. But when I reported this data the first time in 1986 in New York, at the scientific meeting, I got a lot of criticism. How could you be so crazy to put in cells into the brain? I mean, this was based on a paper in Nature where you could demonstrate that there was at least evidence of a functional recovery in rodents due to the catecholamine release.
What was it hostile or?
Well, I would say
not pleasant.
I would say that I had given quite a lot of meetings, quite a lot of presentations, but it was very hostile.
Right.
What is very interesting with this is that the discussion afterwards, where people literally threw rotten tomatoes at me, is printed, so you can read what people said. And it was not pleasant. And of course, I was very worried and we decided, despite this, that the meeting recommended that one should have many more years of animal experiment. We started to plan for the clinical trials with human fetal tissue. There were a lot of the preclinical studies were then planned. We got the permission from the ethical committee. There was an adoption of guidelines for the use of human fetal tissue from the Swedish Society of Medicine. And then in 1987, we went ahead with the first 2 patients in November and December. And I followed them extensively for the first 6 months. We went to London for PET scanning. We had been there also for preoperative scanning. And the data which came out showed that there was minimal, if any, improvement. And there was no survival of the cells. And I remember we had kept absolutely silent. Not to discuss anything. There was a lot of media interest. These were brain transplantations, which were very followed a lot by the media. And I was going to present the data at at the meeting in Jerusalem in 1988, and I know that there was a film crew from the BBC, so it was actually filmed, and I stood there for the second time describing minor improvement, very little effect, and of course, this was of course a disappointment. But on the other hand, I was so convinced that this could work, and I was so convinced that we should move forward. And the team that was involved with people at Hammersmith Hospital, with David Marston and many, Neil Quinn and many of the very close friends and colleagues, we were all convinced that we had to improve the procedure. So we, on the next occasion, or the next, we decided that we should change the transplantation instrument, and we should distribute the tissue more in the putamen, so 2 more patients were operated in '89, and in the first patient of these, after about 3 months, it was quite clear that something started to happen, and he became his mobility and his arm and leg contralateral to the graft became faster, his rigidity was less, and he also started to be improved in the mornings before the first L-dopa dose, and the effect of an L-dopa dose lasted longer. So, and therefore we went with him to PET scanning, post-operative PET scanning in London after 5 months, and it was, I remember that, I will never forget that, because when we saw the preliminary images already when we were in London, it was quite obvious that there was something in the brain. And I think that you can work almost your whole scientific life, just to see that, to see the
eureka moment.
Yeah, it was a moment that the first time anyone has seen anything growing like this. Yeah. I think that is, and I remember I came home and I told my wife that she asked what happened and how did it go, and so I didn't dare to tell her, but after a few days it was confirmed that there was something really, and then of course I think this was a very, very important stage. It was not that it was a treatment for Parkinson's disease. It was the first demonstration that there is that there is a possibility to get survival of new cellular elements in the 50, 60-year-old human brain with a chronic neurodegenerative disorder. Yeah. So it was a very important step for us.
And at that stage, who were your main supporters and collaborators in Sweden? You've mentioned the collaboration with London, but in Sweden, who were the people who were...
We had we have had over many years, I've been leading the team in Lund, and we have had a very, very good team with Anders Björklund representing basic science together with Patrik Bundin. In the clinical program, Patrik has been dissecting the tissue. Håkan Wedner has been responsible for the immunosuppression, which we have given to all patients. Stig Renkrona has been our neurosurgeon, performing all the transplantations.
So that would be the Swedish group.
That has been the Swedish team, and then there have been others. Peter Hagel, who joined me a lot for PET scanning in London and trips with patients. Per Odin, who has also been active in the program. Then we have had this as a European collaboration, not only with people in London, with Hammersmith Hospital, with Richard Frakowiak, David Brooks, Guy Saul, Paul Morish, Paolo Piccini, and with David Marston and Neil Quinn, but then also in Germany with Wolfgang Oertel, Oliver Pogarel, and several others. So it has, and of course, even if I said this was a fantastic moment in my career, of course it is an effort by so many people, which is necessary. But that also means that it has been not just that you have got a paper published in Science and a lot of, but it has also been such a fantastic period to work with people you like a lot.
Of course, this is very important, and I mean, it's interesting to hear you talk about your determination to see it through, which of course Arvid Carlson mentioned in his lecture this morning in the plenary session, that he stuck to his guns, and this is obviously, I think, very important if you're going to make an achievement in science. I mean, looking back now, I mean, what aspect of this work do you feel is the most important scientific contribution that you've made? I mean, of course, you've mentioned some of it, but if you look back on it now, what do you think's been the main achievement from your personal perspective?
I think the main achievement, because I mean, if we think about therapies for Parkinson's disease now and then, so many years ago, at that time we didn't have deep brain stimulation, we didn't have other L-dopa infusion, any of these new technologies which are so good for many patients. And I think what the main contribution, I think, is that we know that the human brain, you can actually replace cells in the human brain. You can get them to survive, they can grow, they can release transmitter, they can become integrated in host neural circuitries. And I think that's a very important basis for the studies which are now ongoing and planned, and with all these new stem cell based approaches and being able, we can reprogram cells in the brain and make neurons of glial cells, and we can make neurons of skin cells, and so there are many more possibilities than originally that we had 25 years ago. And I think that is the main contribution of this.
I mean, people will want to know your views about stem cells and whether you are optimistic about the future, whether they'll work and be a more practical solution to replacing the dopamine system. What would you say?
I think that one thing one has to remember, and I think what I have been doing illustrates that very much, and that is that there is no fast track here. I often get a question from journalists, "Oh, you're not really, why? You have been doing this for so many years. I mean, what has come out of it?" and so. And I think that it takes time, and it's extremely important. But on the other hand, I'm convinced that you have to have, this is a long-term program, and you have to do it very carefully, and you have to do it in close collaboration with clinicians who understand also what is needed. And I think that sometimes it worries me if clinicians are not involved in these translational programs, that you actually end up with something which is biologically, scientifically very exciting, but clinically useless. And what I'm saying is that if we get a stem cell therapy which can improve motor function in patients with 30%, it is scientifically very interesting, but it may be clinically completely useless.
You've mentioned that your father has been a very important influence in your career, especially with the ethical deliberations over this work, but who would you say were other people who were very influential in your career? I mean, you've also mentioned all your collaborators, but I'm thinking more of inspirational people or people who've just supported you, really.
No, I think that there are several. I think that there has not really been a role model for me in this. I think it's more that, as you say, that people who have supported me at very important stages. And I think the first one was actually this professor of anatomy who stimulated my interest in the nervous system. And the second one, Bengt Falk, who created, I wrote some papers with him, but not really about.
So that's how you went into neurology in a way, through your interest in neuroanatomy?
I was interested. I was interested in the dopamine system. I was interested in anatomy. I was interested in the function of the dopamine system. So I actually came to neurology this way. And also I think that my interest was also in my interest in brain repair also. Then Parkinson's disease is actually an extremely good model disease for that. We had a relatively good animal model for Parkinson's disease, at least for this purpose, not for the pathogenesis, but for developing some symptomatic therapy. We could selectively destroy the dopaminergic system. We could visualize the dopamine neuron specifically, and we could also visualize, as it turned out, the dopaminergic system in vivo in patients. So I mean, if you want to study how to repair the nervous system, Parkinson's disease is a quite ideal disease. But coming back to this, where I think that Bengt Falk created this environment which was extremely important for me. And I remember he was then already world famous, and I was absolutely nothing to be when I started as a PhD student. 2 weeks after I started, he invited me to dinner with his wife in his house, and I was so excited about this that he could invite me, who knew nothing, and I remember he offered me some whiskey at the evening, and I mean, just this way of treating a young colleague, I think I will never forget that, and how much it meant to me.
What was he, very left wing?
Well,
not exactly communist.
No. I think that he really
was socialist.
He was very, and he really took care of the people, and I think that people. Since I worked a lot with funding and the research council and stuff, how can you create an excellent environment like that? I think it needs a person like that. Not because he was interfering with my science. I could do what I wanted, but it was just that the environment was such that you actually could spend the day until late evening every day, because that was the most fun thing you could think of.
I mean, if you look back 20 years now, and I mean, you've had to face a lot of controversy in this work because it was so breaking new ground. I mean, would you have done anything different or changed anything?
No, I don't think. I don't think I. And also, I have, even if it has been controversial, and I've experienced quite a lot of challenges, really, when the first 2 American sham surgery controlled studies came out without any real clinical benefit. Of course, I got very worried and concerned, and that was a big challenge for me. On the other hand, as a scientist, my conclusion was not that now it doesn't work, we do something else. My conclusion was that now we have to understand why it didn't work. Why you have patients who can do so well in some of the studies we have done, and why didn't these patients improve? And I also think that if you have that type of, when something goes against you, you should turn it into something which could actually be very positive. And I think we have learned a lot about what is the mechanism underlying graft-induced dyskinesia. What are the factors that determine the outcome of transplantation? For example, a simple thing like patients who had a very widespread denervation in the whole forebrain, they of course do less good as compared to people who have dopaminergic denervation largely restricted to the striatum where you put the graft. These things which are so, in a way, is so obvious, but we didn't know them, and we couldn't detect with the imaging methods we had at that time.
I mean, what would be your advice to young neurologists and young scientists in training now? I mean, based on your experience, and how would, I mean, I'm sure you get many young people coming to your office and asking you what they should do. So what do you tell them? I mean,
I think that I think that translational research to move all the, or not all, but basic neurobiology findings to the clinic, it will be an extremely important challenge for the future. And for that we need people who are trained actually, who are working in the clinic but are trained in basic research and can be the link, because otherwise we will have the basic research will be something, it will be published in the best journals, but it will never reach the clinic. And it's not, therefore I would, if I would give advice to a young neurologist, I would advise to him or to her to have research training in basic research, then go back to the clinic, establish close contacts with preclinical scientists, but taking the lead in projects which are going to, where you move things to the clinic, and also be inspired of your clinical work to address issues in the basic research.
Yeah, which is of course not the philosophy that many people now have.
No. I think that I think that it's just that I think another example, an example of that is how you can go back and forth. Is that in 2007 one of our patients had died, or actually 2 patients had died in our transplantation program, and the pathology showed that a fraction of the grafted cells actually had Lewy bodies. And I remember when Patrick and his colleague Guy Lee, they found those, and he called me, and we were speculating about prion disease and things like that. And suddenly it turned out that this observation in a clinical study which has triggered a lot of new studies, open up a field where Patrick is doing a great work now, many others. But this is, I think that this interaction between clinic and basic research is
That's a very good example.
Positive.
I mean, and it's the same with Carlson's. If Rezapine hadn't been used to treat hypertension,
yes, exactly.
What might not? So that's another similar kind of example.
And I think that is so. I think that in this interface between clinic and basic science,
it's important.
Very important things can happen.
And what are you doing now? I mean, at the moment, what are your present interests and research projects?
I'm now as a senior professor of neurology, which means that I retired from my clinical position a couple of months ago. I've left the chairmanship, and I can now do what I really like and say no if I want to. but I'm very interested in the clinical translation of stem cells. I do a lot of stem cell work. I still share a group together with one of my former PhD students, so we are 2 PIs in the group. We work a lot with trying to generate neurons directly from fibroblasts. So it's a very that is a very let's say basic research. I'm of course very interested in the work on moving now stem cells to the clinic in Parkinson's disease. I know that there are programs both with human embryonic stem cells and with human induced pluripotent stem cell derived dopaminergic neurons. And that, of course, is one of my major interests, to see that comes to the clinic within the next couple of years.
Okay. And outside work, what are your hobbies and interests? And how do you keep a life-work balance?
That is a very good question. I think that the science has been a passion for me since I was very young. I didn't know what to do, really. I didn't know when I came to Lund to study at the university what I should do with my life. But when I started with science, this was really what I wanted to do. And therefore, when we talk about work, I would say that, of course, there is work also when you do with the science, but then there is so much fun with it, and I really love it. And when I met my wife, which is now more than 30 years ago, I think that she realized that was something which will have a great influence on our life.
Be competing with her.
Yes. And I think that but we have actually had a lot of fun with it together. And we have shared a lot of these moments, and our sons have also they have grown up in a family where you have guests from all over the world, and people are, my research group now, I'm the only one born in Sweden, and of course that influences. So it has been, there has been a lot of work, and I travel a lot, but it has also been very, very positive for the family, I think. So I must admit that there has not been so much time for other things than the family and work and pleasure in science.
What do your children do?
Well, they are doing something very different. They are, the oldest one is actually working as a chef and as a waiter, so he's in a restaurant, and the youngest is studying sports and English language and history at the University of Uppsala. I think that they both feel that their parents have worked a lot. My wife is a psychiatrist, and she has been the head of the emergency unit in psychiatry for quite many years. She is now also retired. And our youngest son, he said once that when he was sitting in front of his parents and looked at us, and then he said that, "You two, you don't have a life." So I think that they have got other ideas, and I think what you have to find your niche in life.
So you have no plans to retire? You'll continue to work?
I will continue to work with this as long as I try to travel a little bit less than I did, but and then travel together with my wife more to meetings and so. I think we have had jobs, so it has not been possible to do that together, but we will do that, and I will continue to work with this as long as I can.
Well, Olle, it's been my pleasure to interview you, and thank you very much for agreeing to do this for the Movement Disorder Society.
Thank you.